Good morning. Today we will discuss the advanced management of ANCA-associated vasculitis. I am Dr. Neeraj. We will discuss the advanced management, monitoring and the long-term surveillance of ANCA-associated vasculitis, incorporating the recent changes in the KDIGO-ULR and the ACR guidelines. First is from induction to long-term surveillance. The idea of managing ANCA vasculitis is to induce induction, achieving remission while minimizing toxicity. The primary objective of induction therapy is to rapidly arrest the inflammatory tissue injury within a matter of 3 to 6 months. All guidelines emphasize matching the intensity of immunosuppression to disease severity while aggressively mitigating the treatment-related harm, that is immunosuppression-related harm. In severe organ-threatening disease defined by a threat to life or vital organ dysfunction like rapidly progressive glomerulonephritis, diffuse alveolar hemorrhage, mononeuritis multiplex or mesenteric ischemia. The ANCA regime in these aspects are rituximab, proved to be non-inferior to cyclophosphamide in RAVE and rituximab trials for PR3 associated PR3 positive ANCA-associated vasculitis or lapsing disease or in patients where preservation of fertility is a priority. The dosing is typically 2 regimes, 375 mg per meter square for 4 doses or a fixed dose of 1000 mg given on day 1 and day 50. Second agent is cyclophosphamide, which remains a preferred option for patients with severe renal impairment or life-threatening diffuse alveolar hemorrhage. The intravenous Euro-Lupus regimen, which is 500 mg IV every 2 weeks for a total of 6 doses, is preferred over daily oral therapy due to the lower cumulative dose and reduced toxicity. The revolution that occurred in this guideline is the glucocorticoid revolution. The Pexivas regimen. The landmark Pexivas trial demonstrated that reducing the dose of oral glucocorticoid regimen is non-inferior to standard high-dose regimen in preventing end-stage renal disease or death or dialysis dependency. While drastically, this reduced the risk of serious infections in the first 6 months. So, clinical goal is to target a rapid taper to a maintenance dose of approximately 7.5 mg equivalent of prednisolone by 24th week. Coming to plasma exchange or PLEX, based on the Pexivas, routine PLEX is no longer recommended for all patients with severe renal failure. However, current consensus guidelines still consider PLEX in patients with concurrent anti-GBM disease, which is known as double positive. That is, ANCA is positive, anti-GBM is also positive, in people who are having hypoxemic diffuse alveolar hemorrhage. Complement C5a receptor antagonism is something that happened new. This agent, avacopan, validated by the Advocate trial, 30 mg twice daily, can be utilized as a selective C5a receptor antagonist to replace or substantially reduce the systemic glucocorticoid dose. It has demonstrated superior and sustained remission rate at week 52 and better GFR recovery compared to standard steroid taper. But limitation is that availability is not there in many countries. Now coming to the second group of people who are having non-organ threatening disease, defined by symptoms like severe sinusitis, non-cavitary pulmonary nodules or cutaneous vasculitis without renal or constitutional symptoms. The first line for these patients are methotrexate 15 to 25 mg per week or mycophenolate 500 mg twice to a maximum of 2 g per day, combined with a tailored glucocorticoid taper. Note, MMF should not be used in severe PR3 positive ANCA-associated vasculitis due to higher lapse rate compared to rituximab. Once we have achieved induction in a matter of 3 to 6 months, next is to maintain the remission. The maintenance phase, sustaining remission once induced, is the sheet anchor in achieving success. Therapy must shift towards preventing disease flares. So, relapse is highly prevalent in ANCA-associated vasculitis, particularly in PR3 positive ANCA with upper airway involvement. So, the first line again, rituximab is the gold standard for maintenance backed by Mainristan trials, which proved its superiority over azathioprine, and the dosing is 500 mg IV every 6 months. An alternative agent was the older used azathioprine 2 mg per kg per day or methotrexate 20 to 25 mg weekly once. These are reserved for patients with contraindication for vessel depletion, that is rituximab, such as severe hypogammaglobulinemia or hepatitis B positive. Duration of treatment. Current guidelines recommend continuing therapy for 24 to 36 months following induction. For patients with high risk features like ER3 positive ANCA or history of multiple relapses, extending maintenance to 5 years is increasingly supported because of the cumulative risk of relapse is much higher than continued immunosuppression. Next comes the longitudinal monitoring protocol. How you follow up ANCA associated patients over the long term for relapse or complications. This requires a methodical multi-system approach. Fellows must evaluate for clinical disease activity, drug toxicity and damage accrual at every visit. The lab surveillance usually involved a urine routine analysis and a serum creatinine with an EGFR calculation. A fresh urine analysis with microscopy is mandatory at every follow-up, preferably monthly during induction and then every 3 months during the maintenance phase. A new appearing microscopic hematuria or a single dysmorphic RBC is an early indicator of a renal flare. Then coming to the inflammatory markers. CRP and ESR tracking help differentiate a grumbling flare from an alternative pathology, though they lack absolute specificity. Don't forget about the immunoglobulin levels, IgG. Serial monitoring of total IgG level is crucial for patients on maintenance with rituximab. If IgG drops, there is a risk of virogenic infection. IgG drops below 3 grams per liter, there is a risk of virogenic infection. And this necessitates holding rituximab further or considering IVIG replacement in these patients. Of course, on rituximab, you need B cell monitoring, track CD19, CD20 B cell counts. This can help guide maintenance dosing intervals, whether it may be 6 months or further apart. Although clinical symptoms take precedence over cellular kinetics. Next is a serological conundrum. Interpreting ANCA titers can be tricky. A common pitfall is to alter immunosuppressive therapy based solely on a rising ANCA titer. Treat the patient clinically, not the lab value. A rise or persistence of ANCA has a low positive predictive value for an immediate relapse. However, a rising titer in a previously negative patient increases the statistical probability of a flare in the recent future. It justifies intensifying clinical monitoring and treatment even. So, more frequent urine analysis should be done, more frequent chest imaging should be done, and not preemptive immunosuppression. Next is the screening and prevention of comorbidities in modern ANCA cohorts. The mortality in ANCA cohorts in the first year is not due to the disease and is often by complications of treatment rather than active vasculitis. That is, they are infections. While long-term morbidity is driven by cardiovascular disease and malignancies. So, an infectious prophylaxis should be initiated right at the induction. And pneumocystis, Giroveski pneumonia prophylaxis with trimethoprim sulfamethoxazole single strength tablet daily should always be given to the patients, or a double strength tablet thrice weekly is mandatory for all patients undergoing therapy with cyclophosphamide or rituximab, and should be maintained as long as significant immunosuppression is being given for these patients as part of treatment. Next, but not the least, is the vaccination. Ensure patients receive pneumococcal conjugate series, annual influenza, and shingles vaccine, or zoster vaccine. Ideally, they should be administered at least 2 weeks prior to initiating rituximab to optimize the seroconversion. But many times this is not possible as the patient comes with the disease, and then we will have to go ahead with treating the disease first. Don't forget about the bone health. Any patient anticipated to take more than 2.5 milligram of prednisolone or its equivalent for more than 3 months require proactive bone protection. A baseline DEXA scan if available, optimize calcium, vitamin D intake, and early initiation of bisphosphonates are baseline care standards. Now, as I told, the long-term complications are cardiovascular risk. Always do for cardiovascular risk modification. Chronic inflammation is paired with glucocorticoid accelerates atherosclerosis. ANCA vasculitis have a significantly elevated risk of myocardial infarction and stroke. So, ensure strict blood pressure targets and strict lipid management using drugs. And last but not least is the long-term malignancy surveillance. Patients with history of exposure to high-dose cyclophosphamide carry a lifelong elevated risk of bladder malignancy and myelodysplastic syndromes. So, they should be monitored. So, also occasionally acute leukemia conversion. So, annual urine analysis for persistent microscopic hematuria, even when vasculitis is quiescent, is indicated, and for these individuals who receive cyclophosphamide as an induction treatment. So this is how we should be managing ANCA-associated vasculitis as per the present guidelines.